recording. So good morning again, everyone. Welcome to the Telehealth in Action Meeting Healthcare Needs During Disasters webinar. Today, we are excited to welcome Dr. Tanaz Boyle to share her expertise and insights on telehealth in disasters. My name is Stacy Cockram. I am the Assistant Director of Funded Projects at the Massachusetts General Hospital Center for Disaster Medicine, and I'll serve as your moderator for today's webinar. Next. So this webinar is jointly presented by the Region 1 RDHRS and the Region 1 RESPTC. Both programs are funded by the Administration for Strategic Preparedness and Response, ASPR, within the U.S. Department of Health and Human Services. Next. Just a couple of disclosures for today. So the content today is presented by individual speakers and does not represent the position of the U.S. government. The content also is not meant to be a substitute for any professional medical advice and should be adapted as needed by qualified medical professionals. And the speakers today have no affiliation or financial interest or relationships to disclose. So today during the webinar, Dr. Boyle will explain the differences between teleconsultations and telemedicine and discuss laws and regulations that impact practice across jurisdictions. She'll also discuss the pros and cons of using off-the-shelf platforms in their performance, and then examine examples of telehealth implementation and analyze insights to improve deployment strategies. Next. So now it's my pleasure to welcome our speaker for today, Dr. Tanaz Boyle. Dr. Boyle is an assistant professor of pediatrics at the Boston University School of Medicine and a board-certified pediatric emergency physician at Boston Medical Center. She is a federally funded health services researcher specializing in digital health innovations to improve emergency care for children and adults. Her work explores how telehealth tools can improve patient outcomes in pre-hospital and disaster settings by connecting patients and providers with specialists like pediatric and burn specialists. She investigates barriers to telehealth adoption on provider, hospital, and system levels and develops new simulation methods to test technologies before clinical use. Dr. Boyle leads a multi-institutional team to implement a novel disaster teleconsultation system in New England as part of the Region 1 RDHRS. She's advised the National Emergency Telemedicine Network and the Pediatric Pandemic Network on telehealth strategies for disaster medical response across the U.S. Dr. Boyle also contributes to international efforts to apply digital health innovations in humanitarian response. So welcome, Dr. Boyle, and I'll turn it over to you now.
Thanks, Stacy. I will try to share my screen. Let me confirm you can see my screen.
Yes, we can see your screen.
Okay, and you can see it in the appropriate mode?
Yes.
Perfect. All right. Well, so thank you everybody for the opportunity to talk to you in this forum today. We're going to be talking about our experience over the last several years with the Region 1 Disaster Health Response System and our work in the telehealth working group. So as Stacy said, our research is supported by a grant from ASPR. I also received some salary support from the NIH via a Career Development Award. As Stacy said, the content here is solely the responsibility of our author group and does not represent the official views of either ASPR or the NIH. I have no financial conflicts, but I am a volunteer clinical advisor to Health Tech Without Borders, whose work we'll touch on a little bit today. But I'd like to start first with a story about a place called Bhopal, India, which is in the center of the Indian subcontinent. And in 1984, this city had nearly 1 million residents. And on the night of December 3rd, at around 1 a.m., a poisonous gas cloud leaked from a pesticide plant that was near a poor slum colony in the city. The cloud released over 40 tons of a gas called methyl isocyanate, which is highly toxic, and resulted in the immediate deaths of approximately 3,800 people. 25,000 people died ultimately, and over 500,000 were injured. 200,000 of these were children under the age of 15 years, and 120,000 were estimated to continue to suffer devastating health effects. And not surprisingly, local hospitals were overwhelmed. This crisis was compounded by the fact that there was a lack of knowledge of exactly what gas was involved and what its effects were. And the US corporation with majority ownership ultimately paid almost $500 million in compensation to the Indian government, which is equivalent to about $1 billion today. And families of the dead received an average of $2,200. This was one of the worst chemical disasters in history. And the name Bhopal, which was my childhood home at the time, became synonymous with catastrophe. I was only 8, and my life and those of a million others was really never the same. Well, later, when I was in graduate school in the United States, Hurricane Katrina ravaged my parents' home and community in New Orleans. And then when I was a fellow in Boston, I cared for adult victims of the Boston Marathon bombing. And then, like many of you here today, I was one of just the legions of healthcare providers who faced COVID-19 as global health systems collapsed. And so in each case, access to life-saving emergency care was either disrupted, strained, or overwhelmed. And each time I was left asking myself, how could the outcomes have been different? Well, it's almost 40 years later since Bhopal, and I'm now a clinician scientist and an emergency physician. And I study how we can use technology to give children and adults access to life-saving emergency care wherever and whenever they need it most. And so telehealth is a digital intervention, obviously, that can do just that. HRSA defines telehealth as the use of electronic information and telecommunications technologies to support long-distance clinical care, as well as education, administration, and public health. And the work I'll share now is based on our experience in the Region 1 RDHRS. I'll skip over the objectives here because Stacy has already highlighted them, and we'll just get right into it. So, as you know, ASPR launched the RDHRS program in 2018 to support regional clinical care delivery. And the goal was to enhance or fill gaps in coordinated patient care when existing capacity and capability locally is exceeded by catastrophic events. In Region 1, our mission is to integrate clinical expertise into our emergency response and disaster plans, as well as to enhance clinical surge capability. We have many core capabilities within an RDHRS, but I've highlighted ones that are relevant to today's discussion. In Region 1, we work to engage and mobilize subject matter experts in disaster planning and response. We use tools like disaster telehealth and regional disaster medical teams to augment our limited capabilities. And finally, we provide expertise for large-scale patient movement across systems when they are overwhelmed. Now, during a disaster, local communities can abruptly lose access to basic and specialty care, and the ability to transfer patients may be limited. And the problem is that in the United States today, we still lack mechanisms to establish immediate connections to leverage clinical specialists across jurisdictions, especially if these connections do not already exist. Each RDHRS is tasked with developing and implementing a model for disaster telehealth services. These services ideally support local healthcare delivery via virtual connections to remote clinical specialists who can provide that real-time expertise during a crisis. They should be rapidly deployable and capable of supporting all phases of disaster response and recovery. The goal for these systems, though, is not to replace or duplicate existing systems. It's really to fill in the gaps created by a disaster with temporary services. So, for example, a given event may result in the need for specific types of medical experts that are already in limited supply. Another event may overwhelm local capacity to meet the demand, or delay or prevent transfer of patients to a higher level of care, resulting in a need for additional local support. Anticipating local gaps, though, is really not easy. The duration and the type of need varies by each use case, and within a use case by the parameters of the event itself. So, for example, you may have a natural disaster that can damage infrastructure and displace large segments of a population for a long period. You could have a man-made disaster due to negligence or war or terrorism. I gave you several examples in the beginning that could produce large patient surges that overwhelm emergency systems within hours. So the effectiveness, ultimately, of that response will vary depending on the location, available resources, and the impact on existing infrastructure. Think about how the outcomes for the Boston Marathon bombing might have changed had it occurred in a location without multiple trauma centers within a 1-mile radius. MIC as a gas is no longer made in the United States, but what if the events of Bhopal occurred at one of the 13,000 manufacturing facilities that are operational today? What are we capable of now, today, if this occurred on our shores? Well, we and other disaster groups have been working to try to examine these complex problems. And what I can tell you is that over the last 40 years, the US government and the military have really advanced our technological capability to support humanitarian response in difficult to reach settings. COVID really allowed us to push past other boundaries. We developed new models of care delivery. We waived or lifted legal, regulatory, reimbursement barriers to encourage implementation. And we really witnessed widespread technology adoption through all levels of society. There was enormous health sector innovation through public-private partnerships. And so our group and other disaster groups have been advocating for and working toward a comprehensive national solution for disaster telehealth response. Our shared goal is to ensure that system development is driven by a clinical pull rather than a technologic push. But there's some core questions that really have to be resolved when building a regional or a national solution. So the first is, which care delivery models do we need? Many of our efforts to date have been siloed and specialized, and existing systems are often retrofitted for disaster use. Well, we've been arguing that focusing on a few core models with simple technology could allow us to develop standardized systems that can be flexibly deployed by changing the workforce to fit the need. Second, how do we support timely deployment of a virtual workforce? And I'll point this out multiple times during the talk. We need to be able to care for patients wherever they are, and we need to be able to support facilities even if they are outside existing networks. We need to be able to access experts across state lines and jurisdictions if they are necessary. And in some cases, these services should be available within hours. This is just not possible today. And then last, how do we ensure that our digital solutions are interoperable? We need simple, readily accessible technology that can be used widely across regions. There are multiple video conferencing platforms that exist in both commercial and non-commercial venues, and having a single platform or a suite of applications would have some advantages. It would promote standardization, data sharing, and minimize user confusion, all important features for disaster response. But on the other hand, people can argue that multiple platforms allow for system redundancy and enhanced security and better customization. But we also need to consider that we need states to coordinate within a region and regions to coordinate across the nation. So if we're not intentional about these choices, our solutions may be worse than the problem themselves. So our working group and the telehealth working groups of regions 1, 7, and 8 and the Pediatric Disaster Centers of Excellence over the last several years have collaborated and come up with some minimum requirements for a successful regional disaster telehealth system as a first step toward developing a common standard. And so I'll highlight some of the core elements here. We need a system that can be rapidly activated within hours, that can be readily deployed across anywhere across the region. It should be easy to use by frontline clinicians and experts with minimal to no training. It must be HIPAA compliant, of course, secure against cyber threats. It should be flexible to support a range of use cases in various settings. And then for widespread adoption, we should be able to use it really on any device without requiring hardware or software installation on existing telecommunication networks. And then finally, an effective solution should really promote situational awareness by allowing for rapid communication between health facilities, state and public health partners, and experts across the region. And it should be interoperable to support use across systems and regions to make sure that it's efficient, it's cost-effective, it's easily implementable, and widely adopted. So where are we going to find this unicorn? Well, we used an iterative process to design our platform in Region 1 to try to maximize these features. And I will say it's not perfect, but I think it's a really good beginning. And so I'll highlight a few features that we've tried to maximize. First is the application's web-based, so it can be accessed from any device with an internet connection. User access is restricted by an event-specific passcode, which then can be rapidly disseminated through emergency notification systems. We can offer a range of specialties and flex our availability to meet demand. Users can request both video consults and e-consults, and then care can be documented in real time and recommendations made available immediately. But while many technology solutions focus on the ceiling of functional capability, in disasters, we also need to know how low can the floor go before we lose operational capability. In other words, we need to know when, where, and how these digital solutions are going to fail, as they inevitably will, once infrastructure is damaged, destroyed, or overwhelmed. Anybody who works in a health system today is acutely aware of this as a problem. So ideally, we should select technology that can degrade gracefully as network performance is affected. During the COVID pandemic and even today, many healthcare organizations use off-the-shelf video conferencing platforms to provide telehealth. However, the reliability and the resiliency of these platforms for all hazards disaster response, particularly when infrastructure may be damaged or overwhelmed, is really unknown. And currently, there are no industry standards to guide technology and system development for disaster response. So to begin to answer this question, we characterized how degraded network conditions could affect the ability to maintain telehealth operations. So we conducted a simulation-based study. This was in collaboration with the Medical Device Plug and Play Lab at MGB. We used a digital sandbox that they had developed where network conditions can be manipulated. And we tested the resilience of 4 off-the-shelf video conferencing platforms, which will be familiar to many here today. We tested Microsoft Teams, Zoom, Skype, and WebEx, as well as 2 commercial health platforms, telehealth platforms that were in development for regional disaster response, including those for the Region 1 RDHRS. To simulate those austere network conditions, we manipulated various aspects of network performance and then ultimately examined how this impacted the ability to see, to hear, and to share files, because these are really the core part of telehealth operations. So as you can see here, let me orient you to this slide of data. The blue bars show the threshold levels at which we lost adequate video capability. The orange bars show audio capability, and the green shows file sharing capability. What we found was that there was variable minimum bandwidth requirements across the platforms. You can see, for example, Zoom failed if the bandwidth dropped below 1 megabyte per second, while some of these other platforms could tolerate a lower bandwidth. And that, not surprisingly, video failed before audio. So audio could last longer at a lower bandwidth. All the platforms tolerated up to 20% packet loss, and packet corruption affected, again, video more than audio, but then led to failure of file sharing in all platforms. With all the platforms tested, when the network bandwidth dropped below 200 kilobytes per second, network delay exceeded 5 seconds, and the packet loss or packet corruption exceeded 15 to 20%, communication via audio and video conference failed. So that, to us, said, this is the minimum threshold for network performance to maintain this capability when using off-the-shelf technology. And so this data, we hope, can help planners anticipate when auxiliary equipment would be needed to help maintain operations. Now, obviously, this test has a lot of limitations, the most important of which is that we really varied only one component of network performance at a time. So we may be overestimating platform function. And real-world network performance conditions are unclear. High-quality data regarding this is difficult to obtain, but we're working with industry partners like Ookla for Good to validate the simulation model with real-world data, and I'm going to share some newer work with you now. So this was a pilot study to identify patterns in fixed and mobile network disruption during natural disasters to characterize those network performance and inform our standards. So we wanted to know, was our simulation model, did it even, were those settings or performance characteristics, were they going to be match real world experience? So we examined network performance during 3 major disasters where telecommunications and power infrastructure were affected. This was Hurricane Michael, Hurricane Ian, and the Puerto Rico earthquake. We partnered with Ookla for Good to obtain this data about network performance. What they have is an open source data set, which includes network speed tests that are conducted by millions of people every day all over the world. And this allowed us then to assess network performance and quality as well as availability. So we looked at data for each region before, during, and after the disaster using time series and geospatial analyses. And then we examined network latency, download and upload speeds as measures of network performance. One, the data was spotty. There were substantial gaps in data, but we still were able to identify some really interesting and distinct patterns of impact and recovery of network performance. And so I'll just share some illustrative examples here. On the left is a time series graph, and this is for fixed network latency trends for all service providers in Panama City. And on the right is a similar graph for Puerto Rico. So we've got hurricane example on the left and earthquake example on the right. The red arrow marks the start of each natural disaster. And what you can see is in Panama City before the hurricane, the average network latency is below 100 milliseconds. Translated, this is an acceptable range for most applications. After the hurricane, there's a loss of data until about 2 days later when data collection resumes, but then it's limited and you see a higher latency for up to 2 weeks after. And in fact, at a level that hinders real-time interactive applications. In contrast, fixed network latency was really not affected by the Puerto Rico earthquake. So if we were to extrapolate here, we would say that telehealth use in this setting after the hurricane would not be possible unless we brought in auxiliary equipment, versus after the earthquake, it would still have been operational. During a video call, things like upload speeds affect how others see and hear you, and download speeds affect how you see and hear others. And so when we examined these trends in both situations, we saw no major differences after the earthquake, but we did see declines in download and upload speeds after the hurricane in Panama City. So again, reinforcing this concept of differential degrees of impact and network resilience across different locations, carriers, and disasters. Obviously, there are limitations to this, and our plan is to try to use this kind of concept to permit the development of intelligent model capable of predicting network performance in disasters, because we think that understanding how these kinds of disasters impact telecommunications infrastructure can help us develop resilient systems based on expected network conditions, and use this to set standards to ensure that we can maintain continuity of operations during natural disasters. So now let's switch from tech to implementation. Effective disaster telehealth delivery requires more than just the right technology and the right people. It really requires integration with existing systems, and partnerships with state public health and emergency systems are really at the core of our mission. These are necessary to support the rapid activation and mobilization of a regional capability. And the RDHRSs across the US have taken really different approaches to developing this capability. Some regions are exploring how to leverage and expand existing hospital-based networks, while others like ours are developing new systems and testing platforms to fill specific gaps in response capabilities. So I'd like to orient you now to two terms that you'll hear me use: telemedicine and teleconsultation. Telemedicine encompasses the actual broader practice of delivering care at a distance, and usually involves a provider-to-patient interaction. Teleconsultation is a subset of telemedicine, and it refers to more limited communications between providers for the purpose of getting expert guidance or recommendations. So why does this matter? Well, in either case, the provider has to adhere to in-person practice standards. But the Federation of State Medical Boards and CMS emphasize that telemedicine is really the practice of medicine, and therefore it's subject to the same licensure, privacy, and documentation requirements as in-person care. Physicians have to be licensed in the state where the patient is located, and encounters must comply with HIPAA and state privacy laws. Reimbursement is regulated by federal and state payers with specific billing codes and documentation requirements. I'm telling many of you things you might already know. In contrast, teleconsultation may not establish a formal physician-patient relationship. It's really more of a peer-to-peer communication. This is especially true if the physician is offering advice only. So the legal requirements are less stringent, and many states, in fact, provide a consultation exception to licensure. But unsurprisingly, in the United States, the specifics vary by state. And so the devil is in the details. The documentation requirements depend on whether there's direct contact with the patient, and again, varies by state. So in Region 1, we decided to focus on peer-to-peer teleconsultation for no-notice events because, one, this was a key gap in our capability, and two, we thought that this is a more achievable goal. In this model, we're developing a virtual workforce that's created in advance with experienced, verified, licensed providers. Care is coordinated through a regional medical emergency operations center with knowledge, experience, and access to the regional resources. And then field clinicians requesting assistance can be connected to remote experts via a simple self-guided telehealth platform, which I showed you earlier. Building these expert registries is really an important point of collaboration across RDHRS sites, and ideally we would create registries from regional networks as well as national professional organizations as a shared resource. So here's an overview of how we developed our capability and where it stands today. We started with a prototype model that we developed with input from clinical stakeholders, regional subject matter experts, as well as review of other models of emergency care delivery like 911 call centers and other tele-emergency programs, as well as simulation testing. And then COVID really accelerated our work. We were able to actually deploy twice, refining our process and our workflows as we went. And this helped us identify where our biggest gaps were so that we could continue to develop a system that fit our regional needs. We also refined our implementation toolkit with legal frameworks that we could support system use and define minimum standards that we just discussed to help maintain operations. We're now actively onboarding our first reserve corps of expert teleconsultants with the ABA as an example. So as the RDHRS concept has matured, we outlined a potential mechanism for activating and implementing this regional resource. So hospitals and state partners such as health departments, healthcare coalitions, hospital associations identify their clinical needs according to their normal processes. And when they require assistance, they would request assistance through their normal channels. So they would follow their usual channels to request assistance from either the RDHRS or the ASPR regional office through direct outreach. And then the RDHRS and the ASPR regional office would coordinate to jointly identify the potential solutions within our available core capabilities in order to provide support. Now, it's important to note that the RDHRS does not weigh in on requests for federal assistance, but we work with the regional office and states to offer potential solutions so that we could augment their response. So here's this checklist, implementation checklist, that summarizes what we identified as necessary for effective implementation across jurisdictions. So first, you need a workforce, right? They need to be pre-verified and they need to have liability coverage. We need technology that meets our minimum system requirements, and we need authorization. Currently, we depend on state-level executive orders to authorize practice across jurisdictions, to establish immediate license reciprocity, and to provide temporary waivers of credentialing and privileging, as well as provide immunity from claims of ordinary negligence. Our first field test, an opportunity to test this concept, was in Massachusetts in the first wave of COVID in April 2020, so the Delta wave. We partnered with Society for Critical Care Medicine at the time to give Massachusetts community hospitals access to telecritical care consultations for adults with COVID-19. And here I've mapped our timeline to implementation along against the corresponding case count in Massachusetts using publicly accessible data from the New York Times. By the time our case counts began to rise in April, we had actually, this is before we had even anything but an idea on paper about what our system looks like. So we were able to build a prototype platform and get it ready to test within really 2 weeks of securing an industry partner. We were able to identify and recruit out-of-state experts through the Society of Critical Care Medicine and engage community hospitals by working with the Massachusetts Hospital Association and our regional networks. But it still took us an additional 6 weeks to navigate barriers to licensure, credentialing, and liability. And so despite enormous willingness on the part of all stakeholders, by the time we were ready to start the pilot, we'd missed the surge. Well, in December 2021, we improved our process and we tried again. So in this case, the Vermont Department of Health and the Vermont Health Association requested help for their critical access in rural hospitals. The goal here was to expand workforce capacity in anticipation of a potential surge from the Omicron variant. The hospitals were reporting at the time limited critical care capacity. Their workforce was decimated. Some facilities were unable to transfer critical patients for over 24 hours and calling up to 40 regional hospitals to secure a bed for a higher level of care. So there was an obvious need. This was our first statewide deployment. And in this case, we partnered with the National Emergency Telecritical Care Network, which was a technology development accelerator that was funded by ASPR and the Department of Defense, specifically for COVID response. It was a ready resource and it was really perfect for the job. They had a pre-wedded workforce that was ready to deploy and had made some improvements based on our prior experience. So we thought that it was an opportunity to try again. The COVID public health emergency waivers in Vermont granted immediate license reciprocity. So that was one barrier that was different from Massachusetts, where we had to secure an emergency temporary license. And then the Vermont Hospital Association also agreed to use a standardized credentialing form across all their hospitals. But as you can see, despite these improvements, our service implementation was still delayed. It took a median of 27 days with a range of 20 to 41. From the time a hospital requested help to completing onboarding. And this was largely due to variation in credentialing procedures used by the hospitals. We've also learned a lot about how to have successful implementation from humanitarian response. So Health Tech Without Borders is a global nonprofit organization that was founded in reaction to the conflict in Ukraine. It's a digital innovation hub, and their goal is to offer digital tools to communities to support humanitarian response. The war in Ukraine displaced hundreds of thousands of civilians, mostly women and children, who fled to neighboring countries, lost access to basic healthcare, and then had the additional barrier of language. And so the goal here was to provide telehealth services and virtual health education to support this displaced community. And they were enormously successful. In the first year, they were able to mobilize 850 volunteers from 20 countries. They conducted over 200,000 virtual consultations and reached almost 3,000 clinicians and students with their virtual education programs. The difference was that in Ukraine, they were authorized, service authorization was done by the Ministry of Health. And so they were able to provide remote expertise to local hospitals, psychological support, and mental health, and access to basic health care. This experience allowed us to learn about some of the characteristics of service utilization. So, for example, we learned that healthcare professionals, like surgeons, actually preferred asynchronous communication modes for specialty consultations. They wanted to access burn surgeons for just-in-time education series and for e-consults, but they didn't really want to use video. In contrast, patients and families loved the video and everybody loved to chat. So it gave us, it helped us understand that some of our preconceived notions about how this service might be used might actually be different from what happens in the real world. So what we learned from these deployments was that it's hard to predict the need. So we need flexible technology that can support all those core models of care delivery. Video may not be as necessary as audio, chat, or email capability, but it depends on what the purpose is, the clinical use case is. Simple platforms that can support both synchronous and asynchronous communication are likely to get the most use, and that provider registries and having valid workforce is probably going to be instrumental to the success of adoption and utilization. In Ukraine, the Ministry of Health restricted their support to 2 service providers. This limited the provider pool, but also validated the service offering for both hospitals and patients. And so we think that this really encouraged adoption and use. So finally, given the examples that we've reviewed, let's talk about some of the, a little more detail about some of those administrative and legal barriers to deployment. Effective cross-jurisdictional response really requires that you have knowledge of the regional factors that could influence adoption and implementation of telehealth services. Here's an example. In COVID-19, we observed interstate variability in their emergency licensure procedures. So, for example, in the 6 New England states, Maine and Massachusetts required out-of-state telehealth providers to secure an emergency temporary license. But in contrast, the remaining 4 permitted immediate license reciprocity. And in our field experience, that emergency temporary licensure process resulted in a delay. So if that were to be overcome, we would need an additional mechanism. In many ways, these challenges of delivering healthcare or telehealth care in disaster response parallels the challenges that we have in routine gaps in care, for example, for critical care and pediatrics. So planning for service delivery really requires that you understand what is needed in your region. In 2021, we partnered with the Emergency Medicine Research Network to survey all 189 hospitals and freestanding EDs in the New England region. And our goal here was several-fold, but one of the primary objectives was to identify barriers and facilitators to implementation, as well as the willingness to use these services on a hospital level. In short, we really found overwhelming willingness. 81% of hospitals said that they would be likely to use a disaster teleconsultation system to access specialists if their facility was affected by a large-scale no-notice event. But reluctance to use unfamiliar systems could slow adoption. We found that a third of hospitals that were unlikely to use the service cited that lack of familiarity as a key reason. We also found that we needed policies and procedures to speed disaster credentialing and privileging. Now, we had gotten glimpses of this based on our field tests, but this really gave us a bigger picture across our region. We found that despite limiting our scope of practice to teleconsultation only, not telemedicine, teleconsultation only, that 70% of hospitals would require disaster credentialing and privileging of teleconsultants before system use. And only 28% could complete this process in less than 24 hours, as shown here in shades of green. And approximately 2/3 of them were willing to use a third-party verification system to speed this process. So it gave us a path forward. And then lastly, few rural facilities could maintain adequate cell connectivity to stream video given if they were faced with internet disruption. So what this means is that the facilities with the greatest need potentially would be the hardest to reach if we didn't improve broadband infrastructure in rural America. So we're trying to put these pieces together of, who needs what and when will we need additional support in order to really have effective disaster response. Ultimately, hospital level barriers like licensure and credentialing are important, but they should be ideally surmountable. In Region 1, we have worked to develop tools to facilitate cross-jurisdictional response, but I want to emphasize that we view these tools as a starting point and really not the ideal or optimal solutions. They represent what we can do with the resources and the constraints that we have now, but not necessarily what we could or should do in the future. There's been some progress. HRSA now publishes best practice guides for telehealth for emergency preparedness, and this includes key considerations when planning to use telehealth in emergency situations, things like gap analyses, provider training, joint training exercises with local, state, and federal partners. It summarizes federal and state regulations as well as current policy regarding licensure billing and legal protections for both providers and patients, so important resources that are widely available. There are other important post-pandemic policy updates. Legislation authorizing the extension of pandemic-era Medicare flexibilities make it easier to give and receive telehealth services. But cross-state licensure really still remains an issue without an adequate solution. And in the absence of a national policy or regional compacts that are really developed in advance, we are going to have to still rely on state executive orders for license reciprocity and emergency exceptions. We've also made some progress on speeding provider verification. So Provider Bridge is a tool that was developed by HRSA and the Federation of State Medical Boards. Here, health professionals who register can have their license and certification verified immediately. And thanks to our work, providers can now select RDHRS as an affiliation. So what we hope is that this allows us to build those pre-verified expert registries with a passport where this is an important mechanism for us to maintain rosters of pre-verified health professionals. To speed cross-jurisdiction response, ultimately, we're going to need to determine the feasibility and acceptability of using these strategies, right? We could and we should use existing mechanisms, but many of them have limitations as they stand today. So, for example, most state e-survey programs that verify local healthcare volunteers do not share data with other states. Provider Bridge is a step in the right direction, but more work at integrating these systems is necessary. The IMLC, the Interstate Medical Licensure Compact, that allows for interstate licensure, but it's costly, it's cumbersome, and like everything else is variably adopted. So it's not really a practical solution. There are other model legislation like the Uniform Emergency Volunteer Health Practitioners Act. It provides the necessary waivers, but only 19 of the 50 states have adopted this legislation since it was introduced in 2006. And it currently also doesn't address the provision of telehealth specifically. As we expand volunteer registries, we anticipate that liability concerns could limit longer activations. And we also don't have clear established mechanisms to integrate our systems within the framework of existing regional disaster notification processes. These are going to be really important and essential for future system activation and maintenance. Ultimately, the success of any regional disaster telehealth system is tied to the formalized support of systems like the RDHRSs and the Pediatric Disaster Centers of Excellence. These regional systems provide a predictable backbone across the US where disaster telehealth capability could dock into and be supported. So the following are some considerations as we look to the future. First, what works in one region may not apply or even be necessary in others. So we really need to continue to work towards developing common standards and common and interoperable platforms. The second, we need expert registries so we can deploy the workforce quickly. And in some cases, we will probably be able to get away with regional registries and have mechanisms to support one region with another. But we will still need national registries for some very small expert pools like burn surgeons, where there are only 300 across the United States. The NDMS represents another pre-verified workforce, but obviously is a federal asset, but they may be best suited for prolonged and more complex deployments. Third, everyday preparedness is the core of disaster preparedness. I hear this a lot. We're only as good as our worst day. But the problem is that everyday use cases are not easily applied or modified to support a catastrophe. So there has to be the ability to also adopt new system or a technology, which is really hard to do under stress. So we have to socialize these capabilities into our everyday systems so that they get used. Liability. We live in a litigious society, and so the liability concerns of experts, providers, facilities really have to be addressed, or we're going to have limited adoption and use. And then finally, how do you sustain this all? We envision the current model as a free public service, but how to fund this kind of long-term cost of training, maintaining, and operating a low-frequency, high-stakes system is kind of unclear. We think that the service could be modeled after core systems that operate regionally, like the U.S. Poison Control Centers, which are supported in part by federal and local funds, and could be reimbursed for mission-related costs by states via the Emergency Management Assistance Compact. Nicole Lurie, one of the former ASPRs, said, envisioning the system we want for the future is the first step to building it. And so ultimately, we believe that the work that we've been doing in the RDHRS can benefit both regional and national disaster response strategy. We were developed as an asset for states in Region 1, but we could also be a shared resource to support interregional response via EMAC, and could be integrated into the national strategy as part of ASPR's disaster telemedicine program to support NDMS care delivery. And finally, to assist with civilian military coordination for interagency response for large-scale events. It takes a village. There are many people who have worked and touched this work. I don't even have all of them listed here, but I have many of the core partners. I'd like to highlight also our research partners from the MDPNP lab and MNET, as well as our many collaborators, both within the region and across the US. And happy to take any questions.
Thank you so much for your presentation, Dr. Boyle. We really appreciate you sharing your experiences and your expertise with us today. So now we'll open it up for questions that anyone has. Just a reminder that you can go ahead and submit your questions through the Q&A box and we will get to them. So we can start off with a question that was submitted. The question is about the utilization of GIS technologies for pre and post incident analysis. So if and to what extent do you use geospatial analysis solutions for coordination of resource or personnel allocation, surge capacity, et cetera?
Come talk to me. Yes, I think that we would love to be able to move in that direction. Our team is pretty small, and so we have focused a lot more on the nuts and bolts of developing the technology and developing the workforce and strategies around there. But we've really relied on multidisciplinary expertise to be able to think about how do you utilize technology and how do you utilize some of the newer solutions that are there to give you information in real time. So for example, when we were talking about the network performance, we're really interested in trying to think about can you predict in advance what might happen to a network so that you can bring in auxiliary equipment so that you could utilize telehealth. And I think that GIS technologies falls under that umbrella. I unfortunately don't have the specific expertise there, but if you do and you're interested in this area, please reach out to me and let's talk.
Thank you so much for that.
Can you put my email in there as well, so that people can reach out? Can I put that in the chat? I think I can. Sorry, next question.
Nope. So while others think about any questions again, you can put them right in the Q&A box. I have one that I'll pose for you. So earlier in the presentation, you talked about the duration and the type of need from disasters and how they vary greatly. Can you speak a bit about some of the key considerations for implementing a telehealth capability for more acute responses versus when we're looking at a more sustained response that could last months or even years?
Yeah, that's such a good question, Stacy. So, our experience, and for many sort of practical reasons, was focused on short-term deployments. But in we collected both quantitative and qualitative data from experts each time we deployed to try to understand what we could learn about future deployments. And one of the things we took away was that people were willing to help in a volunteer capacity for short-term deployments. And we see this all the time, right? But when you have a more prolonged need, that you can't rely on volunteers. So I think that when we think about developing these systems for the future, we really need the interim, the short-term gap. What can you do to mobilize the resources that you have, recognizing that you can only ask people to do so much for a short period, and how can you do that most efficiently, versus a more exhaustive and extensive resource, such as what ASPR is developing with the NDMS, where that may be more appropriate for a longer term deployment, but it's going to be slower to mobilize, right? And so what we're hoping is that by developing these systems in collaboration and side by side, that we are addressing two gaps at the same time and trying to share lessons learned, trying to use similar technologies, trying to think about how do we most effectively utilize the resources, the human capital that we have, which ultimately for telehealth is the most limited thing.
Thank you so much. Yeah, definitely a lot of different considerations to think about with the telehealth capability. So appreciate your thoughts on that. You also talked about how difficult it is to shift to disaster systems and technologies in the midst of emergencies. And I know that's a struggle that many in emergency management face. Can you share your thoughts on how we could better socialize disaster system capabilities like telehealth into everyday preparedness, and or what tools we would need to ensure that those systems could be more easily adopted?
Absolutely. So one of our core partners on our team is Maureen McMahon, who is the former Director of Emergency Management at Boston Medical Center. And she has been such a champion of this really from the beginning, and emphasizes how this aspect of socialization will ultimately be is the make or break component. We can build whatever system we want, but if people don't know about it and they don't know how to use it, they're not going to. So the challenge is, how do you address a low frequency, high stakes system? How do you have people get used to using it? So we believe that part of this is exercising with our partners. So with RDHRS, having us be part of the emergency plans, operational plans that states have as a reliable resource, being able to do both tabletop exercises and functional exercises with them will be necessary. And I think that you need to do that, on at least an annual basis, so that people will realize that resource is there. If you think about it, the poison control model is essentially that, right? It is the poison centers exist. As a clinician, emergency clinician, I may call them once a month or once a year, depending on the cases that I see, but I know they exist and I know how to reach them. And so our hope is that we can be a resource with that level of widespread acceptance.
Great. Yeah, it's really important when we're looking at all of our technologies and all of our systems. There are so many lessons learned out there, and I know it's always a challenge to even be able to share out that information so that it's more widely known. So really appreciate your efforts around the telehealth work.
And I think I want to underscore, the RDHRS program, if we were able to continue to expand it and have that be as I said, a predictable backbone, I think having that infrastructure is really the key to the long-term success and viability of assets within the program, right? So without that, this can only be a concept or an idea and won't actually be actualized.
Absolutely. So I recognize that we're approaching the end of our time. So before we wrap up, Dr. Boyle, are there any last minute comments or insights that you want to share?
Please reach out to me if you have ideas, thoughts, feedback. It's kind of fun to put together a talk like this and see where we started. In 2018, this was literally a drawing on a piece of paper. And so it's kind of amazing to see how far we've come, but we've only done it by failing repeatedly and trying to figure out why we failed and how we could get better. And as I showed you that list of people, there's so many people with so many ideas and so much experience that have all contributed to this. So if you think that you have something to bring, you have an idea, you have feedback, you want to help, please reach out to us. We are open, collaborative, and hungry for partnership.
Thank you so much again for being here for today and for your presentation. We really appreciate all the valuable knowledge that you've been able to share with everyone. And thank you so much to all of our participants as well for being here today. As a reminder, the webinar has been recorded, and the recording and the slides will be shared on our rdhrs.org website. So please feel free to go there to get the slides and to also share the recording with others that you think may be interested. And so with that, I hope everyone has a great afternoon and a great weekend. Thank you, everyone.
Bye, everybody. Thank you.